Hi everyone, it's Nigel Giam here, Lead Training Program Director for the St Mary's GP Training Scheme and Director of MentorMRCGP. I thought it would be good if I could just do a very quick video on case selection for the RCA. The RCA is still going to obviously be in place for 2023. We're looking at a remote simulated CSA probably towards the end of the autumn in terms of 2023. But by far the biggest reason why people fail with regards to the RCA is poor case selection. So just wanted to talk a little bit about a few tips around this, because when STs look at case selection, I think primarily they look at clinical challenge, but actually it isn't just about clinical challenge. Specifically, the case that's selected needs to showcase complicating factors, which I'm going to be talking about in a second. So it isn't just about clinical challenge, it's about actually showcasing an angle to the case. But in the context of low clinical challenge, if the consultation could be undertaken essentially by another allied healthcare professional, for example, if it's a medication review request or specifically, a stable chronic disease review, then it's really not going to be of sufficient clinical challenge to make the RCA. This also applies to, for example, going through results where you already know what the diagnosis is. So, for example, I'm giving a new diagnosis of diabetes. This is not going to be of sufficient clinical challenge to actually be submitted for the RCA. One of the big reasons why I decided to put this together is because when we look at poor case selection, we also need to start thinking about case priming. And case priming is actually about what has already happened before the patient's actually walked in through your doors. So if a patient's coming in with a presenting symptom, have they actually seen somebody else before and what has been done? Because if this patient is well differentiated in the sense of lots of investigations have been undertaken, they've seen lots of GPs before, you're going to be pretty limited in what you can actually do, which is going to necessarily make this a good RCA case. You can still use, obviously, such cases, but it's very important that you make the examiner aware quite early on about what has already happened. If you approach a differentiated case, really trying just to reach a diagnosis when the diagnosis is already clear, again, this will be of low clinical challenge. So knowing where you are in terms of a patient's narrative and timeline is very, very important. In terms of the context of clinical challenge, there are certain types of cases that need to be avoided. The college have listed these specifically around, for example, dermatology. They don't really like dermatology at all. They've also listed simple ERTs, simple allergic infections and reactions. So please make sure that you're aware of the sorts of cases that will not showcase well for the RCA. But when it comes to the angle of the case, it's really, really important that we start thinking about the complicating factors. Now, as you can see from the RCGP case selection grid, complicating factors reside within the patient's ICE. So it's quite important that actually a patient's ICE and agenda is opened up earlier in the consultation. Now, it's only going to become a complicating factor if it actually goes against, I suppose, your own agenda. If you're completely in agreement with where the consultation should be going with the context of the patient, because actually both your agendas are matching, then it's no longer really a complicating factor. Complicating factors also reside in a deeper psychosocial perspective. Not a psychosocial history, it's a perspective. So very much about looking at how we are managing patients and situations holistically rather than just symptoms and diagnoses. So when my trainees come to see me, I always ask them really three questions, which is what's the clinical challenge of the case? What is the angle and complicating factors you're trying to showcase? And where are we in terms of narrative and case priming? Now, if you ask these three questions of yourself and also of the cases that you wish to submit, you should have quite robust answers for that. If you don't have robust answers for that, then typically this means your RCA case is not going to be of sufficient quality for submission. So very important that we understand case selection. A few examples just to run through. So I'm often asked, are 2-week waits any good? Again, the 2-week wait is only going to be good if it's a complicating factor. That is to say the patient's not expecting a 2-week wait. Thereby you showcasing interpersonal skills, thereby showcasing how you work through the management of risk and diagnostic uncertainty with a patient who potentially was not expecting that conversation to happen. If the 2-week wait aligns with the patient's expectations, it no longer becomes a complicating factor. Testicular lumps, face-to-face consult. If you imagine, for example, a young patient coming in and maybe they're worried about this testicular lump being testicular cancer, and actually we find out that it's highly unlikely to be testicular cancer, and that obviously the benefit of having this patient now face-to-face is you can examine them, and let's just say, for example, something more benign is found, then actually readdressing the patient's agenda and risk containing this rather than unnecessary risk escalation would showcase as an angle to the case. Breast lumps, you'll be aware that the college have specifically specified that these no longer are cases that are very good to submit specifically around maternal and reproductive health, because a breast lump is quite undifferentiated. So inevitably, 99% of these breast lumps will end up under a breast clinic referral, and generally, again, a 2-week wait. So again, these are cases to be avoided. Contraception, well, if it's just a routine contraceptive request, ask yourself, could this be done by, for example, my nurse practitioner? If that's the case, then it's not going to showcase well specifically for the RCA, but perhaps, if we're looking at teenagers who are presenting with dysmenorrhea, menorrhagia, and actually are thinking about contraception moving forwards, then yes, you might have a good case here on your hands to showcase how you would approach talking with teenagers, assessing their capacity, especially in the context of Gillett capacity and Fraser guidance. So these could be quite good cases to use. Follow-up going through results. Again, if you already know what the diagnosis is, this is not going to really showcase well as an RCA case. The caveat to this, I suppose, is in the established long-term condition, if you have a result which shows an acute deterioration on an established long-term condition and there is a narrative behind that, there's a complicating factor as to why that's happened, and then this potentially would make for a good RCA case. So I hope you have found that useful in the context of case selection. Do think about these 3 themes: case priming, challenge, and angle. And feel free to subscribe through the website, mentormededucation.com. Lots of free resources there, also on the YouTube channel, and courses that you can apply for where we will showcase both challenge and angle to your RCA case submissions. Well, take care of yourselves and have a great day. Many thanks.